আমার স্ক্রিন কি দেখা যাচ্ছে তানিয়া?
হ্যাঁ দেখা যাচ্ছে। ওকে
দেখা যাচ্ছে।
So thank you. I am Dr. Mustafa Aziz Shumon. Welcome you all in our today's discussion. As you know, today's topic will be on metastatic breast cancer. In our last discussion, we have covered the endocrine, that means the hormone positive metastatic breast cancer. Today, we'll try to cover HER2 positive breast cancer. And in the next episode, we'll try to cover the triple negative breast cancer. As you know, this is the first subject. So initially we thought that we can cover it in a single episode, but eventually it found that it would be very difficult. So we split into two segments. So as we have you know very well, Dr. John Collier, consultant oncologist, first NHS Trust UK. Dr. Zakirullah sir, I think she doesn't need any introduction. Right now working is West Coast University Hospital NHS Trust. And a new face in our family, Dr. Tajia Irfan, right now who is working as a specialist medical oncologist at Royal Marsden Hospital, UK. So welcome you, Appa. Thank you for joining. So we have two local faculties today, two bright new faces. As you know, Dr. A.T.M. Sajjad, a very bright radiation oncologist, right now working as a in radiation oncology. And another bright face, Dr. Shafatul Jahan, who is right now working as the head of the department, medical oncology and radiation oncology, Mao Fisher Hospital, Chittagong. So thank you, both of you, for joining. So thank you, Sharjad Bhai. Thank you, Shefa. So as a custom, we used to start our program with a few words from our inspiration, our president, Professor Amy Heiser. So, sir, I would like to request you to say words and to start the program.
Bismillahirrahmanirrahim. I'm going to start our session today. And you know, as already Kamal has said, that if we are dealing with these day-to-day problems that we face in Bangladesh, how we can treat it and how we can improve this thing. This is the discussion. Our faculty are John Connie Beer, Ajay Irfan, and Zakirullah all from England. Our local faculty are Safat Jahan, Chittagong, Sajjad Hussain from Dhaka. My heartiest welcome to all of you. That really, I think we should start immediately.
So thank you, sir. So Tanya, can you please pose the poll question over here? So here is the question. I would like to request all the participants to post their answer over here. De novo metastatic disease, HER2 positive, ERPR negative, HER2 positive, 60 years old lady. So what would be your treatment option? So only two participants right now. Free. May I request you all to answer the questions? So as the stem is quite big, I think I will give 10 seconds more time for the answer session. So only 12 out of 27. I think we should participate more to make it more interactive. So thank you, Tanya. Just please close the close the question answer. So this is the question. A 60 years old lady, initially diagnosed as a de novo metastatic breast disease, metastatic breast cancer patient. Immunohistochemistry, ERPR negative, HER2 positive. So metastatic HER2 positive breast cancer. So at first, I would like to ask the question to Dr. Shifa to Jahan. So if the patient, suppose if the patient is in your chamber, what would be your decision, Shifa?
Good evening, everyone, and thank you, Vaya. Uh, I have to answer in both way. In my institution, I have a different protocol, and in my chamber, I can apply different protocol. For financial constraint, you know better. So in my institution, it is a charitable organization, and all the patient comes there are poor patients. So I cannot follow the real guideline here. That is the docetaxel, trastuzumab, and pertuzumab. I cannot follow this one. But in my chamber, I usually advise this guideline, but both combination, I have not started a single patient. I advised, but no one could afford it. So in chamber practice, I use the taxane and trastuzumab as neoadjuvant setting, but in my institution, I never use this combination because of their financial problems. So I simply start taxane with platinum.
Taxane and platinum, or taxane or trastuzumab? Herceptin.
Herceptin cannot, they cannot afford. In that cases, I use only docetaxel and platinum.
So you, so even in HER2 patient, HER2 positive patient, you opted for docetaxel and carboplatin, right?
Because they cannot afford it.
Okay. I got your point. Thank you, Shifa. So Dr. Shahjad Bhai, what's your opinion?
My opinion, according to guideline, the docetaxel, trastuzumab, and pertuzumab is the main treatment option or category 1. But what same before, my colleague, I'm agree with her. In our practical life, we also follow that protocol same to her.
So it's in the same chemotherapy protocol, like Shifa, she used to taxane and platinum. So you are with the same protocol, taxane,
Yes.
platinum?
Yes.
So in HER2 positive, taxane and platinum is the routine practice, right?
Yes.
Okay. So let's hear from our overseas faculties. So Dr. Tajia Appa. So what would be your decision? হ্যাঁ আমি শুনতে পাচ্ছি আপা।
আচ্ছা, first line এখানে has to be Cleopatra trial, which is now reaching 58% survival. তারপর 58 months, so that is 58 months কত, almost
6 years.
6 years. তারপর এখন নিউ ডাটা যেটা এসছে 8 years, 37% patient lived over 8 years. So after Herceptin, as you know, Herceptin is a miracle drug. After Herceptin, practice changing, such a huge survival benefit we didn't get from any other treatment. So this is Herceptin pertuzumab. এখন আমরা quite struggle করছি because we have so many HER2 targeted therapy. So first line, if you cannot, first I would like to say, now we are using Herceptin pertuzumab as a subcut injection, subcutaneous injection, that is a combined injection called FASGO. Now and which is moving towards the home delivery. So if 6 months to 1 year will be successful, then we will send it to home delivery. So obviously, this is all applicable for the Western countries where people has a thick wallet or they can afford. For Bangladesh, I don't know why it is docetaxel and carboplatin. You can use here either any taxane with Herceptin, and Herceptin is a biosimilar drug now, and the price has come down. In the adjuvant setting, there is a lot of talk about whether 6 months of Herceptin or 1 year of Herceptin. And there is many trials, I don't remember the trials, like SOLD and other trials, SOLD maybe 9 weeks. So what people are saying, after 6 months, the benefit from Herceptin is less than 1%. And will you expose these people? Because it's adjuvant treatments are curative treatment. Will you expose these people with the cardiac toxicity? Though it's reversible, but will you? So that is the reason they are moving into 6 months, but obviously patients are so comfortable and they fought so hard for the Herceptin, they are not trying to move into 6 months. So this trial, 6 months versus 1 year or 9 weeks versus 1 year, has very difficulty to recruit people. So what we see in the adjuvant treatment, that metastatic treatment, that comes to the adjuvant treatment, and what we see in the adjuvant treatment, then we try to bring it to the metastatic treatment. So I completely agree. We are in a country where people cannot afford things, but if you consider the first line, if you cannot afford Herceptin, Pertuzumab with docetaxel, then docetaxel or weekly Taxol with Herceptin, at least for 6 months. And it is ER negative. She hasn't got any other treatment option endocrine wise. And also, we don't know what is the multiple metastatic site. So we need to know, I think it's bone as well. So bone therapy, zoledronic acid or denosumab has to be there.
Yeah.
So
Okay.
thank you, Appa, for your nice elaboration and nice descriptive analysis. So I saw that Dr. John Coniver has joined. So thank you, John, for joining. So can you hear me?
I can, yes.
Yeah. We are discussing regarding a HER2 positive de novo metastatic disease. So in your routine practice, what would be your choice from this sequential answers? So A, B, C. What would be your answer?
C. C would be out of those, but I'd normally use weekly Taxol rather than docetaxel.
So in a country like Bangladesh, where people has to buy the drugs from their own pocket, so trastuzumab, pertuzumab, in my routine experience, I never saw more than 5% patient can afford this 12 blockade. So in a country like Bangladesh, where we do have constraints, so what your suggestions, how we can proceed if the patient cannot afford this dual blockade?
So I would go, if dual blockade's too expensive, then you have to have trastuzumab. You have to have some form of HER2 targeted therapy. So I would go taxane and trastuzumab.
Okay. So you are desperately with any kind of HER2 blockade therapy?
Correct. I wouldn't give single agent chemotherapy. You know, HER2 blockades transform the management of HER2 positive breast cancer. So, you know, it would be retrograde not to give some form of HER2 targeted therapy.
So thank you, John. Jakir has joined. Jakir is there?
No, not yet.
Okay. The Western peoples are very much in line with dual blockade combinations as expected. And in Bangladesh, we know that this is the guideline practice, but due to the constraint, we barely managed to give. So this is the situation. You could see that though we know that HER2 subgroup has some poor prognostic features, but after the invention of this, HER2 directed therapy, you could see now the prognosis of HER2 positive disease is quite good. You could see this is top on ER positive and TNBC. So HER2 positive group, the main weakness here is the driver, that is the HER2 directed therapy. That is the main option of treatment modalities. So why this is coming? So HER2 blockade is the main weapons. So Dr. Shefa, you know, I know that you are in a limited constraint, but for academic purpose, you know that everybody is decided to go with the HER2 directed therapy. Now the question is, what is the evidence? Why to add and when to add? You could see this is the trial. This is known as the Slamon trial. This is the first trial published in 2001. And you could see that adding trastuzumab with chemotherapy, the overall survival increased around 5 months. And this is overall survival. So with this data, with this source of information, with another numbers of publication, that right now the ESMO grade it as MCBS score 5, that is the highest score in metastatic setup. So trastuzumab is the treatment of choice for metastatic breast cancer. Now, the question came, So in a country like Bangladesh, if we cannot initiate it as early, so if we think to give trastuzumab later in later course, so what would be the outcome? So here you can see that this is a very nice trial. Here you can see that trastuzumab docetaxel and docetaxel is 2R. And after that, when the patient in the docetaxel arm progressed, so they are crossed over to receive trastuzumab. And you could see that later application of this trastuzumab might result in good outcome. But if you initiate the trastuzumab very early, you could get the maximum benefit. So if you want to initiate the trastuzumab, you should start it as very early. So now the question came. So which type of chemotherapy? Is it always taxane? So here you could see the taxane is the main player, but as you know, the taxanes come with some toxicities. There are neurotoxicities, lots of neutropenia over there. So they have tried, they are the phase 2 trial, but you could see with these trials that vinorelbine and capecitabine is as equal as good with taxane. So you could think regarding these two drugs. So not only think about the taxane, there are another options. So now the question came. So why this is the dual blockade? So as already Dr. Tazi Irfan has said that the Cleopatra trial has showed that the docetaxel trastuzumab pertuzumab combination resulted 8 years overall survival, 40.8 months versus 57.1 months. So 17 months overall survival difference with addition of pertuzumab. So that is the essence of practicing with this dual blockade. And it is the 8-year median overall survival, keep it in mind. So these are all we have in our hands right now in metastatic HER2 positive breast cancer. If you consider only chemotherapy, what kind of chemotherapy? It can be taxanes, it can be anthracyclines, anything can be there. Since 2001, the overall survival is 20.3 months. After the 7 trial, chemotherapy adding with trastuzumab, 5 years benefit. But the pertuzumab trastuzumab combination arm, that is the Cleopatra trial, even with docetaxel trastuzumab, the progression overall survival is 40.8 months, and the dual blockade 56.5 months. So you could see from chemotherapy 20 months to 56.3 months addition of the dual blockade. So we should think about this outcome. So what is the ABC guidelines? This is the 5th version. You could see the previously untreated patient with HER2 therapy. Chemotherapy with trastuzumab pertuzumab is the preferred option. And the main backbone of chemotherapy is taxane, either docetaxel, paclitaxel, or you can think vinorelbine, nab-paclitaxel, or capecitabine, anything. So Tanya, let's move to the second question. So this is complicated situation. The patient initially treated with Herceptin, and after 11 months completion of trastuzumab, she develops metastatic disease, and again is ER/PR negative HER2 positive disease. So initially she was exposed to trastuzumab. So what would be your treatment option in this scenario? Within 11 months, disease progressed in metastatic phase. So only 4 answers. TDM1 in okay. More are in favor of TDM1. Good. So only 11 participants. Okay. So Tanya, close the results. So again, I come to our local fellows, that is Dr. Shefa. This is a critical situation. The patient initially exposed with trastuzumab, but unfortunately within 11 months, she progressed in metastatic disease. What would be your pick?
According to guideline, I would like to advise B, that is adotrastuzumab, but I practiced here lapatinib and capecitabine more for this case.
So, okay, so when there is a progression within a short interval, that is the trastuzumab. So still you are thinking theoretically, even in the theoretical world. So you think that you should continue trastuzumab, pertuzumab, any kind of combination, even after progression with 11 months.
Yes, it is the golden drug. I can try first, then I can go for another options. But in my setting, I mostly use this kind of drug, that is lapatinib and capecitabine more I used. And I found them stable for a long period also. And in some patients, I got the liver as well already diminished or disappeared after a few months. Also.
Okay, Shifa, forget about you are in Bangladesh. So you are in an ideal situation. You do have all the drugs available for you. So in that unique situation, what would be your decision?
B, adagrasib.
Okay. So if the patient progressed to trastuzumab in the first line in metastatic setup, you want to consider TDM1, right? Okay. So Shajjad bhai, what would be your decision? You are in an ideal world. Don't discuss
Ideally,
about the constraint.
ideally, I choose the answer B, of course. But in the situation of our practical life, my choice is capecitabine and lapatinib. If possible, patient afford. If patient not afford, capecitabine only.
Okay. So let me discuss again to Dr. Shefa. Suppose here the question is the patient progressed to 11 months. So if the patient progressed on during Herceptin therapy, so in this context, do you think continuation of trastuzumab has any logic? Patient on trastuzumab after 6 or 7 cycles, patient progressed. So is there any logic to continue trastuzumab?
No.
Sajjad bhai?
No, no.
Okay. So let us hear from Dr. Tajia Appa. Dr. Tajia Irfan, can you please add your opinion regarding these issues?
The trick is here, the main thing is at 11 months. So I am taking that 11 months from her starting trastuzumab. So definitely she will not be eligible for, in our setting, Herceptin and pertuzumab. I will go for option 2, TDM1. Now things are changing. There is a new drug coming, TDXD, which we are still not approved, but we are getting hold of it through the different ways. So the paradigm of HER2 positive breast cancer in metastatic setting is changing. So my option will be B.
And so Appa, you have mentioned that the 11 months, so you have calculating some monthly digit. So intentionally, I have put the 11 months over here. Can you please clarify these issues to our audience? So what is the trick for deciding?
So usually we do not use Herceptin and anthracycline together because two are cardiotoxic and one is reversible, one is irreversible. So we start using it with any sort of taxane. So if first Herceptin goes with the taxane because of the synergy they have, so 11 months from the last trastuzumab, I'm thinking that it's 11 months from the last taxane as well.
So is there any time duration? So suppose if the patient progressed after 14 months or 25 months, should you consider trastuzumab to initiate trastuzumab again?
12 months and over, they can have Herceptin pertuzumab. So obviously, because we have to get it by funding. So our thing is 12 months. But if you see 11 months and 12 months, if your straight is 11.5 months because your patient can afford it, I don't know. Maybe you can give Herceptin and pertuzumab here. But that in the trial, it has to be 12 months. So we are following the guideline from the trial only.
So Appa raised a very important issue. So even in the first line metastatic setup, the patient if earlier exposed with trastuzumab, but the duration is more than 12 months. So you can still consider this trastuzumab and pertuzumab combination because this is a long run. So we have to store our all resource in for the later run. So Dr. John.
We are adding a different HER2 blockade as well. So it's a dual blockade. So in that way, yes, and I can see she's ER negative, so there is no endocrine treatment. Yes, it will be TD1.
So Dr. John, what could be your decision?
I'd normally give trastuzumab enzametane. So if they've progressed on trastuzumab or trastuzumab plus pertuzumab, I'd normally switch them to TDM1 second line.
So Dr. John,
or first line first line progression on adjuvant therapy.
okay, so I'm not going in this discussion. So you can see that even in the Cleopatra trial, 88 patients were there who has exposed to trastuzumab previously, and they have found a good result. Not the magnitude was as equal as with the those not exposed to trastuzumab earlier. So why you were keen to move in TDM1?
I'd say that's normally what our protocols are, departmental protocols are. So if they're was the patient in the adjuvant setting, did you say? They were currently on adjuvant trastuzumab?
Yes, they were in the adjuvant setting, trastuzumab was there, and 88 patients, they have developed a metastatic disease, and they treated with this dual blockade, and they got a better overall survival. So why to jump in TDA1 when there is an option for this trastuzumab and pertuzumab combination? That is my question.
So in the NHS, you wouldn't be allowed to give them the addition of pertuzumab if they've already received first-line targeted therapy. So NICE doesn't allow us to carry on with the trastuzumab and add pertuzumab to their treatment in the relapsed metastatic adjuvant setting. So we're not allowed to do that. It's not funded.
So thank you, and thank you, John, for your opinion. So both of our overseas faculties are interested with the TDM1. So here you can see that if the patient is previously exposed with HER2-directed therapy, that's trastuzumab, and progressed, so what option would you have? So this is the FEREXA trial. You could see that again initiated with Herceptin, with Zeloda, Herceptin, Zeloda, and pertuzumab. And you could see that FEREXA trial, the progression-free survival is 2 months. But in the overall survival, you could see there is a significant difference. But the problem is there, though it has a significant difference in overall survival, but the FEREXA was not designed to find out overall survival. So at last, they can conclude that with this formulation, you can have some overall survival. But the FEREXA gives us an idea that even the patient received trastuzumab earlier, so you can think combination trastuzumab pertuzumab with capecitabine. So here both of us, our local colleagues are very interested to give the lapatinib. You could see that combination of lapatinib with chemotherapy is inferior than trastuzumab CT combination. So lapatinib can be an option, but you can think the trastuzumab earlier, even the patient is exposed to trastuzumab if the duration is more than 12 months. And if the patient is previously exposed with the dual blockade after progression, I don't think that there is any data to continue this dual blockade therapy. So if only trastuzumab is given, you could think again reintroduction of trastuzumab if the progression after 12 months. So in the later lines, you could have all this chemotherapy, you could choose with the combination therapies, and is the preferred option in first line of therapy if the patient is previously exposed to trastuzumab therapy. Now the question is, why TDM1? You could see all the trials, the Emilia study, Teresa study, they have shown that the lapatinib capecitabine combination and the TDM combination, there is better overall survival. That's why all the Western peoples are in favor with this TDM1. I am very, very correct with you. I am with you with this all data. We know that the TDM1 is a better combination than the conventional lapatinib capecitabine. And these are all in overall survival benefit. So TDM1 is the treatment of choice. So you could see that the ABC guidelines also has stated in the same way, if the disease has progressed, the TDM1 is the second line treatment better than lapatinib capecitabine. So you should think TDM1. So now, my question to Dr. Kazia Irfan. If the patient progressed with TDM1, what next? What you have to do in this situation?
Well, this is where it's changing now. We are recently having got the result for the Breast Destiny 03 trial. And there is a new drug conjugate which is coming, is called TDXT. So it is also, other name is Enhertu. So now we are trying to place it, is it before TDM1 or after TDM1? And there is also result from the two trials. One is called Hard2Climb. So as a TKI, tucatinib has better penetration in the CNS. So we are preferring tucatinib on the top of lapatinib. And there is also other trial, which showed NALA trial, which showed as well that TKIs has good penetration in the brain. So as a whole, it depends upon what the option you have. If you do not have any option, I will say after TDM1, you can go to with Herceptin with any other combination of the chemotherapy. Vinorelbine, eribulin can be done. And if it is after TDM1, if you get hold of the TDXT, that is okay, because TDXT you can be given after, I think, 2 to 7 line of HER2 targeted therapy, and also the TKI, tucatinib or niratinib will be the good option as well.
So thank you, Appa. You have mentioned all the available names right now. So Dr. John, so what's your opinion? So are you in tucatinib, deruxtecan, or anything else?
So at the moment we've got, in terms of our NHS practice, we've got Enhertu available, so trastuzumab, deruxtecan's, things in process, so tucatinib and neratinib are kind of in the pipeline, I would say. But third line, I would go to Enhertu.
Okay. So let's see what we have in the literature. We have Hard2Climb study that after progression with TDM. So tucatinib, trastuzumab already, Tajia Appa already mentioned, and you could see that tucatinib combination, 2.2 months difference in progression-free survival and 4.5 months difference in overall survival. So we are talking about third line therapy. So patient has exposed with trastuzumab, pertuzumab, TDM1, and now we are talking about what else we do have. So with tucatinib, 4.5 months difference, but the toxicity is quite high over here. And initially, tucatinib was thought that it was a good drug for brain metastasis. And this is a very interesting find. You could see that the other combination, even the trastuzumab combination, you could see at 12 months, all patients had died. But in the tucatinib arm, you could see the around 25% patients still alive. So tucatinib has a great role in the CNS activity as per the Hard2Climb say. So tucatinib can be an option even with the patient has with brain metastasis. So let's see what the ABC guidelines have said, that the tucatinib, trastuzumab, capecitabine can be an option, but we should think about the overall survival that is only 4 months. And it also comes with higher toxicities. So now come to another option that is mentioned by Dr. Tajia Irfan, that we could see the Destiny trial. It was tried with, though it is the phase 2 study, that the deruxtecan combination, it is also a trastuzumab antibody conjugates. And you could see the trastuzumab deruxtecan is coming in front, but still it is in phase 2 lines. So we are not in very much interested with these drugs in Bangladesh situations. But we should know that after TDM1, we have 2 drugs, at least we do have, that is the tucatinib we can consider, and another drug is deruxtecan. So let us summarize the overall progression since time, that the capecitabine in the second line, if it is progressed, 16.2 months. If you add capecitabine with leptinib, 18.8 months. Capecitabine level in another study, it has showed that 20.5.1 months and TDM1 30.9 months. So in second line, you should think about TDM1. If the patient cannot afford, so you can think about lep-cap combination. Ultimately, it will give a 25.1 months for patient. And the third line, in the later line, we have already discussed that we have tucatinib and deruxtecan. So now a very interesting question to Tajia Apa, and later I will discuss with Dr. John. So sometimes we got some patient having docetaxel trastuzumab first-line treatment. And after certain cycles of chemotherapy, PET-CT scan shows that complete response, complete metabolic regression. So in this situation, how long you will continue with this dual blocker treatment? Dr. Tajiapa, complete metabolic regression.
Well, that is a very difficult question. The reason is after 5 years, we try to stop people, but it's difficult to stop the people. So as I don't remember exactly the trial, I think it is Paru's trial. So that one is still people are keep going 7-8 years. We discussed certainly because these drugs are new. We don't. It has cardiac toxicity, but we don't know other status. So if they started with this very small volume metastatic disease, after 5 to 7 years, we discuss whether they want to stop with a very close follow-ups and observation, or they want to carry on. So in fact, any metastatic disease, when it has a complete metabolic response, the idea is to carry on. But with HER2 targeted therapy, it's not that clear cut. It's very gray here. So 5 to 7 years, then you discuss what your patient think about it, and if they want, but if they have toxicity, certainly you stop. That is the cardiac toxicity. But we don't see much when they are in long term. The cardiac toxicity is more common in the long term Herceptin pertuzumab. As I said, it's a very gray area. How long to continue after metabolic complete response? After 5 years of therapy. So I will ask Dr. Cornier as well, so what he thinks about it.
Dr. John, so what's your decision? What you do in practice? Complete remission. How long you will continue this dual blockade?
As long as they're tolerating it and as they're responding to it. So I have to say, I know of only one patient in my clinical practice that we stopped therapy after 5 years. The biopsy confirmed relapse disease. And she's now probably 10 years since she was first diagnosed with relapse disease, and she remains disease-free and well. So everyone else, I've got to say, they tend to carry on, and I don't know, I've got anyone else who's got beyond 5 years without relapsing, progressing. So that's where I am currently.
So actually, this is a very gray zone. So we really don't know when to stop. But as per the nature of these medications, so we should think as long as possible how so far the patient can tolerate, considering the toxicity. This is so far right now we do have. But we are thinking in the proper window period when we can really omit this dual blockade, but still we don't know when to stop. So the last question, Tanya, can you please pose the question? So this is a similar type of patient, de novo metastatic disease, but this time our ERPR is positive. So triple positive breast cancer patient, de novo metastatic disease. So, okay, most of the participants are with earlier started with chemotherapy, trastuzumab followed by endocrine therapy maintenance, and now endocrine therapy to ovarian suppression, AKA inhibitor, and HER2 therapy. Okay, Tanya, you can stop this poll right now. Again, Dr. Shefa, triple positive de novo metastatic disease.
I would like to advise option C for this patient. Chemotherapy, trastuzumab and pertuzumab combination, followed by maintenance endocrine therapy and HER2 therapy.
Okay, Sajjad Bhai, what is your opinion?
The patient is 42 years old, premenopausal. In case category 1 treatment is C, chemotherapy with trastuzumab with pertuzumab followed by maintenance ET plus HER2 therapy. But if patient is premenopausal, so in competence of Bangladesh, in our practice, we follow the D.
That is the ovarian suppression, aromatase inhibitor plus trastuzumab. Okay, Sajjad Bhai, let me very clear. So here you can have two driver mutations. That is the endocrine stimulation, and another one is HER2 stimulation. So there are two driver mutations. So which one you think that is the most potent driver mutations? ERPR positive, HER2 positive. Which one is more potent? Which driver is you have to consider first in this situation?
You asked me the question?
Yes, Sajjad Bhai.
Oh, please repeat again.
ERPR positive, HER2 positive. Here you have two driver mutations. That is endocrine stimulation over there and HER2 stimulation is there. So which one you should more potent and
HER2.
Okay, Shefa?
Yes, HER2.
Okay, thank you. So let us hear from our expert, Dr. Tajia Appa.
Well, I will go for C.
So, so your opinion is to start with chemotherapy with trastuzumab, pertuzumab, followed by maintenance therapy, right? Thank you, Appa. Yeah, please.
There is a data coming out from Monarch Har, but it's still in UK. We are not we are not allowed to, or it's a phase 2 trial data only. So we are not using CDK4/6 with HER2 targeted therapy as yet.
Okay. So let us discuss. I have seen that John has out of his chair. So you could see there are two clinical trials, mainly though the patient number is not very much high. So you could see that from these two trials, we found that endocrine therapy alone quite bad results. So endocrine therapy is not your treatment of choice. So endocrine therapy with HER2 treatment, HER2 therapy did not show overall survival benefit. So in this situation, your main treatment composition is chemotherapy with any source of HER2 blockade. So you cannot think that if the patient is HER2 positive disease, so you can just overshadow the role of HER2 positive. So main driver force is HER2. So you need to think that you have to block the HER2 pathway by any means. Even she is in ERPR positive status. So here is another study, that is the alternative study. You can see that they have tried to show the role of ovarian endocrine therapy, that is lapatinib, trastuzumab AI, and lapatinib AI. You could see the more beneficial result found in the chemotherapy combination arms. And as Appa has already mentioned, that the Monarch study, you could see that they have tried to see whether in this condition, whether we can avoid the chemotherapy or not. They have tried in ABEMA, trastuzumab, fulvestrant in 1 month. You can see there is no chemotherapy. ABEMA, fulvestrant, there is no ABEMA and trastuzumab. And you could see the trastuzumab and investigator's choice chemotherapy. And what they found that arm A versus arm C. Arm C contains chemotherapy. We could see that the arm without chemotherapy, there is a 2.6 months better progression-free survival. So overall survival yet to come, but the exploratory analysis shows, I'm not very convinced about the year, but though there is 3 months difference in overall survival. So Appa, you have already said few words regarding this HER2 study, but do you think based on this study, Monarch study, we can avoid chemotherapy really in this situation?
Well, this is a very good data. Obviously, CDK4/6 coming with full weight now in every respect. We are trying in neoadjuvant setting that are all in trials, but metastatic setting, they have put their mark already. So this is a good option because patients will be less toxic, exposed to the less toxic treatment, and also we have many treatment options, but still it's limited. So that will delay their chemotherapy a bit further. So it's opening a more options. But still, as I said, it's in UK, we are only exposed to the what we in the routine practice. So it is not coming, and it is not a trial what we are discussing at the moment. So in the HER2 treatment paradigms, there is a change, huge change. You know, there is so many drugs that TDXD, TDM1, tucatinib, PKIs. And there is one more drug coming, which is the second line drug conjugate called CYD 985. It's a TULIP trial. So there is lots of drugs for the HER2 targeted therapy. So where they will fit in, that is in the practice we'll see, and we have to look at the toxicity. Obviously, CDK4/6 will come in the HER2 and adjuvant, neoadjuvant setting, because given that their data in the metastatic setting. So, but not yet. But that is a good option. The PFS data is promising. So this is a less toxic drug, good option.
So thank you, Appa.
Dr. Jakarla has joined.
Yes, sir. Yes, I have seen. I'm coming to Yakazai. So as per the ABC guidelines, you could see if the triple positive disease, so it is reasonable to use endocrine therapy after the initial treatment, that is the chemo and dual combo therapy. And when the chemotherapy is off, you can initiate the endocrine therapy along with the anti-HER2 therapy. So that is all from this triple positive breast cancer. So Zakir bhai, welcome. Can you hear me?
I can hear you. Assalamu alaikum. I'm extremely sorry because I was really busy and really, I came about 3 o'clock in the morning. So I totally forgot to join in. I'm really sorry for that.
No problem, Zakir bhai, no problem. Thank you.
Tanzila Appa is there, so she's very knowledgeable. I know her very well, so I'm sure I'll just listen to you guys for 5-10 minutes and then I'll contribute whatever is necessary. Is that okay?
Okay. So we are talking about HER2 positive metastatic breast cancer. So we are at the end of our discussion. Now I will pick some question from the chat box.
Okay, I'll definitely talk about my personal experience with HER2 positive metastatic cancer in a minute, but of course answer those kind of questions, and then I'll add on.
Okay. I'll come over to you. So question in the chat box. I think the Shefa will answer this question, Shefa and Sajad bhai. So in the initial answer in the early de novo metastatic disease, you have said that your routine practice is taxane with platinum. Now the question, why platinum? What is the evidence?
Previously we used, actually now there is no evidence, so we should avoid the platinum, I think.
Right. So that is the learning, Shefa. So in this situation, metastatic breast cancer, so you think that sequential monotherapy is the treatment of choice. So you think one by one chemotherapy. You should not put all your medicine in a single setup. So it will cause you toxicity without any further benefit, except in case of visceral crisis or where you can think the patient is deteriorating very fast. So in that situation, you can consider the polychemotherapy. Otherwise, single agent chemotherapy, either docetaxel, paclitaxel, or whatever you can find. And not only that, I need to mention that in this situation, everybody is very keen to involve the taxane. But there is also meta-analysis that has shown that in this situation, even you are not thinking about trastuzumab therapy, anthracycline is as good as docetaxel. So you can think about these cheaper drugs also. Next question. Arman, if cannot afford anti-HER2 therapy, my opinion favors single agent therapy. Okay, so Arman, we have discussed. Platinum is the shorter FINA at the trial 6 months. Okay. What about lapatinib against trastuzumab as a cheaper option? The question raised by Dr. F.M. Kamaluddin. So lab versus trastuzumab, which one and why?
Well, lab versus trastuzumab, I will go for the Herceptin. So definitely you can use, as I said, we have to strictly follow the what is the NICE guideline and what is the funding available. But as you can do, you can use Herceptin with different combination of chemotherapy, vinolobine or irinotecan you can use. And lapatinib is not a drug of means that has made lots of noise, because I just forgot the trial. I think it's Lantern trial. I forgot it. So it's a adjuvant or metastatic trial. But anyway, there is better TKIs. I don't know cost-wise will it be helpful. But tucatinib and the niratinib, if you have to choose, you can choose between these two, not lapatinib.
So thank you, Appa. Let me supplement Kamal Bhai. Lapatinib capecitabine combination. The overall survival is 25 months. And if you can interpret the data from Cleopatra, that is the without pertuzumab combination, docetaxel trastuzumab, the total overall survival is around 40 months. So you can have a 15 months better overall survival with this trastuzumab combination rather than the lapatinib. In the first line unaffordable patient, the same type of question. I hope Dr. Arman has got his answer. We are challenged with some drug in the relapse in after 6 months. Why there we need to wait up to 12 months in case of trastuzumab? The question is, if the relapse after 6 months, why there we need to wait up to 12 months in case of trastuzumab? Kamala, can you please ask your question?
No, the question is normally what we do when we use a chemotherapy, if any patient fails after 6 months, we re-challenge with the same drug. But in trastuzumab, we are waiting for 12 months. If it's 12 months, we are not keen to use trastuzumab. That was the discussion. My question is why, in case of trastuzumab, we cannot re-challenge within after 6 months. That was my question.
So, well, it is not that you cannot, but the trial, what they showed that it has to be, it's not only with the Herceptin, there is a second drug called taxane. So when you follow the Cleopatra regime, you have to be on taxane, Herceptin and pertuzumab. In other cancer type, re-challenging is okay, permissive and fruitful. But in breast cancer, we tend not to re-challenge because maybe one is the reason that we have many treatment options, and the second is that re-challenge is not very much in practice in the breast cancer. So if you run out of the treatment option, then you can use whatever you want to use. But because of so many treatment options, there is no, first of all, pertuzumab is an expensive drug, and there is very less room to re-challenge.
So Kaunbhai Appa is very correct. So you can there is another trial I have tried to show that there is a probably DAS trial. They have shown that even with trastuzumab on progression, you have to continue with trastuzumab with changing the chemotherapy. There they have found 3 months progression-free survival. The main issue is there that you have to continue with any source of HER2-directed therapy, whether it is trastuzumab or anything like that. But most of this trial, they have included the patient after 12 months. That's why the 12 months issue has come. A question from Limapa, instead of tucatinib, can you use lap with trastuzumab and lapatinib, trastuzumab and capecitabine? So this is the question. So if we don't have tucatinib, can we use lap, trastuzumab and capecitabine?
Yes.
Yes, Appa, you are the panel of expert today.
So the thing is that you can use any TKIs, but we try to reflect in our practice from the trial. So tucatinib is a drug of choice in hard-to-climb, and it has a better CNS penetration. And you know that patients with HER2-positive breast cancer has a 20% chance of developing brain mets. So if you do not, I don't know, is tucatinib not available or it is more expensive than the lapatinib. If you don't have option, yes, you can. Any combination you can use, because these are all good drugs. But as I said, our practice always reflects a trial, and cost as well we take in account. So tucatinib will be the choice here. But if you do not have, yes, you can use lapatinib.
So thank you, Appa. Again, another question. So if there is a complete metabolic regression, so as you know that we are in a resource limited country. So if the dual combination with docetaxel after few cycles of chemo and combination therapy, recent PET-CT shows that complete metabolic regression. Should we continue dual blockade or we can avoid pertuzumab in that sense?
Well, as means John has said, and I said, the practice is to carry on. Though you get metabolic response, the practice is carry on. But because we are reaching beyond the 5 years, some people are reaching to the 7 years. So is there a chance of stopping and restarting? I think that is not a bad idea. But in NHS, what we don't get the funding back again. So we lose the funding. So there is a 7 to 8 weeks time between two treatments. If we do not use them, it's very difficult to get back. So what we tend to carry on, because which is effective drug, which gave us a complete metabolic response, and we don't want to lose the funding, and we want to keep the more treatment option for this patient. But if you have a choice to re-challenge it, then yes, if you will stop and 6 months they progress, after 6 months you can re-challenge them if you have the option. But most of the time in the breast cancer we see re-challenge doesn't give the effect as in the first line. So re-challenge sometimes doesn't work or works for short time. So yes, you can do that, because but as I said, in UK practice mainly reflects the trial, and also funding issues are there.
Thank you, Appa. So let me hear from Dr. John Conivier. So let us give your opinion regarding today's discussion, the HER2 positive metastatic breast cancer. So a consensus opinion from you.
Yeah, coming back to Kamal's point about 6 or 12 months, generally my feeling is, Kamal, that when it comes to monoclonal antibodies, we tend not to re-challenge, you know. So within 12 months, and it's quite interesting, you know, when we use other monoclonals, VEGF, immunotherapies, I don't know, we don't seem to have a lot of data at the moment in the re-challenge space. So I guess 12 months, I don't know, seems a bit arbitrary, you're right. In regards to the points earlier, it's in the NHS, we're very defined. These drugs are expensive, as we all know, and so our treatment protocols really are defined on the nice tech appraisals and the data that they analyze, and that essentially leads to the sequencing. And so we have very strict rules on what we can use and when, and we're not really allowed to bend from that. And also, if we stop a patient's treatment, you know, and want to then restart it if they relapsed, that wouldn't be permitted. So essentially, keep it going for as long as you can, because if you stop, you won't be allowed to go back to it later if you wanted to. The only thing I would say that may change that in future is the advent of biosimilars. And I know we haven't touched on that today, but, you know, fingers crossed, biosimilars will allow us to offer patients, you know, international standard of care drug combinations at a fraction of the cost. But the drug companies always seem to be one step ahead. So take Roche, for instance, pertuzumab's coming to its end of life cycle in terms of patency. And now Roche have created Phesgo, you know, subcutaneous combination antibody therapy, which is expensive and extends their patency for another considerable number of years. Yeah, that's a little bit of the skeptic in me as well. So.
Thank you, John, for sharing your all experience and issues. So Let us hear from Dr. Zakirullah sir. Zakirullah sir, what's your
Thank you very much. This is
yes.
Thank you very much. This is definitely very. I mean, this role is played by the oncologist. As a surgeon, I've got very limited role. When some of the tumors, most of the tumors are actually responding very well with, especially Herceptin, HER2 positive cancers. And I said that I'll talk from my own experience or from my own practical experience. Before this pertuzumab combination, we used to use just some Herceptin. After the pertuzumab trial with Herceptin comes preoperative neoadjuvant chemotherapy and then surgery followed by postoperative treatment. We're seeing remarkable results. Of course, it's been documented already. As an oncologist, you all know about that. But initially, patients were not getting pertuzumab as a pre-neoadjuvant treatment. And chemotherapy, if their tumor is more than 2 centimeters or so, sometimes we consider about 1 centimeter. John probably knows better. But I'm seeing remarkable results whenever we take their specimen out or whenever we take their breast out. This amazingly, from my practical experience, 40% patients have got complete resolution of this whole thing, as you know already from documented from the research as well. And maybe it's increasing more and more now. Of course, at one point, probably we surgeons will lose our jobs. Oncologists will take over everything. Now, personal experience. One of my aunties, she's from Bangladesh, and she was 78. She had HER2 positive cancer with fungating tumor, and also gone metastasized to lung. And 78 came to see us because by the time, I don't know why she didn't actually expose to any one of the oncologists in Bangladesh. Came here, and of course, most of our friends, as usual, and she's 78 or 79, how long she's going to live, so no need to treat her, just take the breast out. But of course, with the help of John and our colleagues as well, we treated her absolutely completely. She had mastectomy. Before that, she had Herceptin and pertuzumab, privately though, and then, sorry, she did not have any pertuzumab, only Herceptin. But interesting thing is 6 years now, she's still alive. She has still got lung nodules you can see, but probably not active. Because then she doesn't have any symptoms with her cancer at all. So it's promising results. So don't give up. My message is, as a surgeon, an oncologist will try. I know it's very expensive drug, but I know it's very cheap if you buy it from India. The same company is selling much more cheaper because most of my patients go back to Bangladesh, and I ask either Kamal or Aziz Bhai from Brigadier Aziz because they have got some link in CMH, and they are surviving. So it's a fantastic drug from my point of view as a surgeon. That's what I'm saying. And last thing, if there is any lesion left behind or some sort of cutaneous lesion, we find out later on. John and I actually have a good deal. He always sends all his patients, and I do something called reversal abdominoplasty. I did show you some pictures before, but in future, I'll definitely discuss about that. So don't give up. That's the message.
Thank you, Zakir Bhai. You are very correct that the last 3 decades, most developed subsite is the HER2 positive disease. So even in the metastatic setup, you can think that 10 years overall survival is possible right now with the combination of this HER2 therapy. So thank you all our participants. So now, as we are already finished our timeline, so we want to hear a few words from our scientific secretary of FM Council, sir.
Thank you, Shuman. It was a great discussion. I think all the medical oncologists conferences are very busy with always the new options of HER2-directed therapy. And we are so happy to hear that most of the drugs are discussed today. So what you say, that is very true. Sometimes we cannot afford it, but we should know about it. We should think about it. And we will discuss that we cannot afford it, so we are not giving. So knowledge should not have any boundary. We may have a capacity of use it, but we should know everything. And another thing very important, you and Shafa discussed that whenever we are treating a patient, whether it's metastatic, we should not excuse that anything can be treated to a metastatic patient. Even a metastatic patient, we should treat with evidence. Because today, breast cancer metastasis, as you said, can live for 8 years, 10 years. It is not on the trial data, out of the real world data is also there is a survival like that. So we are quite optimistic, and we are so happy to see the wonderful participation and the wonderful discussion. And thanks to all the faculties, local and foreign, for joining us. Please support us so that we can continue. Thank you very much.
Thank you.
Thank you. So, Tanya, can you please show us the last week results? Last week winner results. So these are the winners for last week: Devraj Chakraborty, Aditi Chaudhuri, Dr. Rupam Johar. Congratulations for your winning that quiz last week. So you will get your prize within a very short time. So thank you again. I would like to give a special thanks to our academic partner Roche for their continuous support. Now I would like to request our chairperson, Professor M. Hai sir, to conclude this session. Over to you, sir.
That was a very nice discussion today. Everybody was very kind to discuss anything. And though it is a very difficult subject, Dr. Zakir said we should not give up. We should continue. We have to continue. Thank you all very much for your participation. Hope to see you again next Sunday. Thank you all very much. Allah Hafiz.
So thank you all the foreign experts and all our local faculties. So thank you for joining. And our next week topics will be the role of radiation therapy in breast cancer. The second episode, it will be covered by Dr. A.F.M. Kamaluddin sir. So hope you all will join there in next week, same time. So thank you again.